Hello, I'm Henry Fields, Chair of the Division of Orthodontics at the Ohio State University College of Dentistry. Today I will be discussing the paper Pavlak, Fields, Beck, and Firestone entitled Orthodontic Informed Consent Considering Informational Load and the Serial Positioning Effect. This report is the most recent in a series of 4 investigations into the effectiveness of new informed consent methods in orthodontics dating back to 2009 that quantified patient and parent immediate recall and comprehension. This latest study had 2 goals. First, to determine whether using a standardized short video to reiterate the issues related to informed consent when used with an informed consent presentation that exhibited a limited number of critical issues at the beginning of the presentation improved recall and comprehension. Second, what have the 4 studies taken together taught us about the best practices of informed consent? In a nutshell, using the standardized video, no matter how appealing, to reiterate the points of consent had no beneficial effect. The benefits of going from general to specific or specific to general when talking about core issues of enamel decalcification and gum disease, external resorption, pain and retention and relapse, or custom issues specific to each patient like impacted teeth or surgery had minimal effects. The evaluation of the body of work of the 4 studies was more instructive. Recall always exceeded comprehension, and patients generally mastered 40 to 60% of the material, and parents 60 to 70%. Because the subjects of all the studies have been drawn from the same patient and parent pool, excluding families who have previously participated in these type studies, they are statistically comparable, which makes comparison of the results reasonably fair and unbiased. We selected specific groups from the 4 research studies for comparison because they could help us tease out critical issues. Using a form with improved readability and a supplemental audiovisual slide presentation compared to the standard AAO form had multiple significant effects. Patients' overall recall and parents' overall comprehension were improved. Adding chunking, which presents like concepts together to the new methods, resulted in small gains. But chunking, along with a readable form and a supplemental audiovisual slide presentation compared to the standardized AAO form, had even more positive side effects. Recall and comprehension were improved for both parents and patients. The results are a bit discouraging when we consider how much of the information is left on the table and how ineffective the AAO form is when it's used by the vast majority of orthodontists. This may simply be the case because orthodontics is not a life or death issue. But more likely it's because we try to make too many points, usually 18 or more, when 7 to 8 appear to be the maximum that learning theory suggests that short-term memory can manage. It's quite possible that patients and parents would be better served by understanding the core and up to 4 custom issues using a readable form and audiovisual supplementation while letting them gain the other points discretionarily. We are not obliged to tell the patients and parents every possible outcome, no matter how remote, if they mask the recall and comprehension of the most fundamental and likely outcomes. That method remains to be tested by further clinical investigation and the legal process.